Hi, I'll try to make this short, sweet, and simple. I thought that I could skip this talk because we are running short of time, but like Fifi said, I must do this talk. All right, so I'm talking about the very simple block, adductor canal block, which has been debated between Amir and Azrin just now. So this is just a very simple block. I think everyone should learn how to do this. The key is so where is the adductor canal? So when do we do it and why do we do it? So the indication is for any knee surgeries, total knee replacement, knee arthroscopy, and saphenous vein stripping or harvesting, medial foot and ankle surgeries to supplement the sciatic nerve block. And why do we do it? Because it's like Amir and Azrin said before, is because it's motor sparing. Okay. So adductor canal begins at the apex of the femoral triangle and ends at the adductor hiatus, where the femoral artery becomes the popliteal artery. It's a triangular in cross-section and it lies posterior to the sartorius muscle. So it contains vessel, the femoral vessel, saphenous nerve, and nerves to the vastus medialis. If you do this block, the coverage is at the knee, the medial aspect. Let me see. Medial aspect. Can't really see the pointer here. Medial aspect up to here. All right. So anatomy. So the borders of the adductor canal, you look at it, medially is the sartorius muscle. Posteriorly is the adductor longus or adductor magnus, depending where the more distal it will be the adductor magnus. Anterolaterally will be the vastus medialis. And you can see it contains the nerve, the vastus medialis, femoral artery, femoral vein, and the saphenous nerve. And you look at this here, ini terbalik actually, terbalik. Okay. In this journal published in the Regional Anaesthesia and Acute Pain, it dissects the adductor canal and looks for what nerves actually contains in the canal and whether these nerves actually supplies the nerves, the knee joint capsule. So you can see that nerve to the vastus medialis, NVM, via the intramuscular branch and the extramuscular branch within the adductor about 20% and 7%, and the contribution knee innervation is quite a lot, plus, and plus. And the saphenous nerve via the infrapatellar branch, and also quite a significant amount of supply to the knee capsule, plus. And actually, there is something we call a subsartorial plexus. It's a deep plexus of mixed nerves of nerve of the vastus medialis and also saphenous nerve origin via the deep genicular nerves. So this contributes a lot to the innervation of the knee joint capsule as well. The anterior branch of the obturator nerve, you can see, is not considered found in the adductor canal, and the contribution nerve innervation is actually not so much, it's plus or minus. All right, so with this, how do we do adductor canal block? Very simple. You put the probe, linear probe, at the anteromedial aspect of the thigh. This diagram here. So I remember when I first did this block was back in 2017, 2016 in Selayang Hospital. The time Afifi was talking about it, so I said, I also want to do it. And I heard Amir the block didn't work for Amir, the patient was shouting in pain. So there was a case of a total knee replacement being done. It was an elderly woman who refused spinal anesthesia, and the total knee replacement was done under GA. So just full GA, fentanyl morphine, and the patient was shouting in pain in the recovery. Pain score 8/10. I was being called because I was a pain specialist. So let's call Dr. Khoo to come and settle the pain for this patient. I was thinking, what pain? Maybe it's the best time for me to try out this adductor canal block. So it's after the surgery, patient was in recovery. So I did an adductor canal block. Fifi was there to help me. So the pain score, I think we injected quite a bit of local, about 30 to 40 mils of local anesthetic, and pain score went from 8 to 2, which is good, right? Okay, that was the first time I'm doing it. So there was, of course, there was a lot of studies saying that the effects and the outcome is variable. So, and we know that if you look at this, if you look at NICE, how they describe the block being done, the probe is in transverse position in the anteromedial thigh junction between the middle and the distal third of the thigh, LA volume 10 to 50 mils. If you give LA volume of 10 to 50 mils in a total knee replacement, most of the time it's not enough to cover the analgesia for total knee replacement. That's my experience. If you keep on putting a probe in the junction between the middle and the distal third of the thigh, most of the time you get it work, sometimes you don't get it work. All right? So like all regional analgesia technique, the process of scanning is very important. It's just not a point where you look at it and that's where you inject. So you must be able to recognize the structure, even though this is a simple block. And the point of injection is from the scanning process, you identify the structure and you find the best point from your scanning process. So if you look at this, there are few structures that you should look at when you do a adductor canal block, all right? So you can see the sartorius muscle, SAM. You can see the adductor magnus and adductor longus muscle, which is ALM and AMM. You can see the VMM, which is the vastus medialis muscle, okay? Your probe member is in the anteromedial aspect of the thigh. So your needle comes in plane from the lateral aspect of the thigh, all right? So you deposit your local EV, another thing you must be able to see is the pulsating femoral artery. Once you see that, you deposit your local anesthetic in plane, your needle comes in at the lateral aspect of the vessel. Okay? Simple, right? Okay, you can see this is another diagram from Nysora. Okay, all of the structures are here, and you deposit the local just lateral to the femoral arteries. So adductor canal block, so if you want to do it the proper way, there's always a process of scanning. So you put your probe at the anteromedial aspect, start halfway between the ASIS and the patella, the distal femoral triangle, all right? So you scan, you look for artery and you trace it upwards and downwards, all right? So you look for all the muscles, the sartorius, the vastus medialis, the adductor longus, and adductor magnus. You trace, and then you must find until you look for the plane until you see the medial or border of the sartorius muscle intersects the medial border of the adductor longus muscle. That's the best place to inject for the true adductor canal, all right? So A2, B2, if you go at A2, you can see that the medial border of the sartorius is not well seen yet. So you go to B2, that's where the medial border of the sartorius muscle intersects with the medial border of the adductor longus muscle. That's where you inject. So there's no fixed point. The best way, if you do a dynamic scanning, scan around, look for this view and you inject. Okay? Because if you inject if you inject too proximally, all right, you may be near the femoral triangle and local anesthetic may be spread proximally to block the motor nerves of the femoral nerve. If you inject too distally, all right, okay, some of the local anesthetic may have spread distally into the popliteal fossa to block the popliteal plexus, which is good, but you may miss the saphenous nerve, which has already pierced the vasto-adductor membrane, and you may not be able to block the saphenous nerve. All right. So this is another study that showed that if you inject a distal adductor canal, then they have some spread to the popliteal plexus. Okay. So tips. Okay, last slide. So superficial femoral artery is easier to visual proximally. If you can't see it distally, you can't see it at the midpoint, go proximally and trace it downwards. All right. Okay. Higher volume of LA will likely produce more motor blockage because of the spread. But if you're doing a distal adductor canal, you may need to inject higher volume so that it will spread more proximal to block your saphenous nerve. Careful aspiration before injection because you're very near the vessels. And the artery, if you inject, if you're in the right plane, okay, most of the time we can see the artery being compressed momentarily when you inject, and there's a recoil when you stop injecting. Okay. So sometimes you're worried that if you're doing a distal adductor canal block and you're worried that the nerve may have pierced the vessel adductor membrane. So as you pull out the needle, you may want to inject some local anesthetic at just below the vastus medialis just before you pierce the vastus adductor membrane. Right, that's it. Thank you. Short and simple.